I want to welcome everybody on the webinar. And they're welcoming also our friends from Bolivia who I saw connected, and any of you who wants to participate to the colloquium. This is one of the colloquium on global health that we organize every month. And my name is Damiano Rondelli. I'm the Chief of Hematology-Oncology in the Department of Medicine and College of Medicine, and I'm also in the Center for Global Health in the College of Medicine. We're grateful to have today a speaker with us, Dr. Henry Ddungu, who I want to introduce. We'll introduce in a second. I want to remind people that you can actually ask questions through the chat at the end of the talk, and we will be welcoming any question. Dr. Ddungu will have his lecture, I think, in about 45 minutes, and then we're going to be happy to have more some question and answer together. So welcome again to the colloquium on global health. I'm honored to introduce Dr. Henry Ddungu. Henry is a physician. He graduated from Makerere University in Kampala, and where he also got his internal medicine training. He also received his training in hematology at McMaster University in Ontario, Canada, and his PhD from Makerere University in Uganda. He's currently the senior consultant and the head of the Division of Medical Oncology and Hematology at the Uganda Cancer Institute. Uganda Cancer Institute is the main cancer institution in the whole country of Uganda. He's also an honorary lecturer at Makerere University, where he teaches basically hematology and oncology. He's an adjunct associate professor at McMaster University in Canada, and a honorary lecturer in the Department of Medicine in Mbarara University of Science and Technology in Uganda. Dr. Ddungu has worked for a long time in palliative care organizations in Uganda and Africa, and he's been providing services to terminal cancer patients as well as AIDS patients, and he's also an advocacy manager in for the African Palliative Care Association. He got also a fellowship in international pain policy at the University of Wisconsin-Madison, and he's a principal investigator in multiple clinical trials in hematology-oncology, and he's the co-author of over 30 papers in peer-reviewed journals. Importantly, right now, Dr. Ddungu is also been one of the selected participants in our global BMT training program that we organize every year at UIC for BMT's blood and marrow transplantation. And we look forward to a long-lasting partnership with Dr. Ddungu in Kampala to establish the first bone marrow transplant program in Kampala, in Uganda, and in the whole Eastern Africa. So without further ado, I am grateful to Dr. Ddungu for giving his lecture today, and we look forward to his lecture. Thank you.
Thank you, Dr. Rondelli, and I hope you can all hear me.
Yes, we can.
I need to share my slides again. Ooh. Can you see my slides?
Not yet.
Okay. Okay. Let me share again.
Yes.
Okay. There you go. Thank you very much once again, Dr. Rondelli, for the wonderful introductions. Today, I want us to really go through what it is in Uganda about cancer care. And for those of you who have not been to Uganda, I think you've read about it, but Uganda is a beautiful country that has a total of about 241,000 square kilometers, most of which is land, and then we have water of about 43,000 square kilometers. The climate is generally tropical, with generally rainy with 2 dry seasons, December to February, January to August. Just in case you want to come in when it's not raining, you get to know that. The northeastern part of the country, the Karamoja subregion, is generally semi-arid, and the terrain is mostly plateau with a rim of mountains. The highest elevation is the Margareta Peak on Mount Stanley, which is part of the Rwenzori Range, and this one borders between the DRC and Uganda. So where you see DR or the Congo and then Uganda, that's where the population is about 47 million people as of 2023 estimates. Well, as you know, the key facts about cancer is that cancer is a leading cause of morbidity and mortality worldwide, with approximately 19 million new cancer cases and almost 10 million deaths occurring. The global cancer burden is expected to increase, and the challenge is that the increase might move towards where we live in Africa, as it has moved away from this other side. It is the second leading cause of death globally, approximately 70% occurring in low and middle income countries. The economic impact of cancer is significant and it is increasing. We have so many patients presenting with late stage disease. There's a lot of inaccessibility to diagnosis and proper treatment. Only 35% of low-income countries reported having pathology services available in the public sector. And this applies to, many of us who are coming from less developed countries or low-income countries. So this is a graphic again to emphasize that cancer is the second leading cause of mortality globally, only second to cardiovascular diseases. Going to the early in the days, we have all heard about, hopefully, about Sir Albert Cook. So from his pioneering work, we refer to him as the father of Western medicine in Uganda. He had meticulous records from 1897, 1904. These were reviewed by Dr. Davis, and in their reviews, they concluded that a number of cases that Dr. Albert Cook saw were actually cancer. But of course, they didn't have the capacity to, do all the investigations. But this suggested that cancer was present in Ugandan population right at the onset of Western practice in the country. Up to date, Uganda has a very high morbidity and mortality due to cancer. The pattern of cancer might be different from what is observed in developed countries. We have a lot of infection-related cancers, Kaposi sarcoma, hepatocellular carcinoma, cancer of the esophagus, cancer of the uterine cervix. So infections contribute significantly to the number of cancers that we see in Uganda. Research has always been a foundation of cancer care in Uganda, and for cancer care to start in Uganda, it all started with research. These are studies that were published by Dr. Bucket and published in the Journal of British Journal of Surgery in 1958, where he described, a sarcoma that was involving the jaws in African children. He was able to do pathology, and you look at the histopathology, and the cells that you're seeing in black and white. So he looked at 38 cases of a sarcoma that was involving the jaws of African children and described them and referred to this as a syndrome which had not previously been fully recognized, and that it is by far the commonest malignant tumor of childhood seen at Mulago. Mulago is the main hospital in Uganda, and all these children are presenting with jaw tumors, as you can see in these images. So they went on to do more studies, and the preliminary observations on response to therapy for the African lymphoma, they looked at all the patients who were treated in this series and were attending Mulago Hospital, Kampala. And the treatment was supervised by one of them, Bucket and his friends. And the series includes the Ugandan patients. They were all given methotrexate orally in doses of approximately 1 milligram per kilogram of body weight per day for up to 8 days. And children usually received 11 to 20 milligrams. They also gave them cyclophosphamide that was given in dose of 30 to 40 milligrams per kilogram of body weight. Many of the children actually responded. For example, this one who had a jaw tumor, after treatment, it disappeared. But some of them had really extensive tumors that even after treatment, when the response happened, they had massive and uncontrolled growth of the maxillary tumors. And these were occurring, really rapidly. In their summary, they said that the pattern of response to chemotherapy that was observed in African lymphoma was described. And the very encouraging results achieved following short-term dosage, together with the phenomenon of delayed response, suggested probably an immunological response on the part of the patient. Unfortunately, many of these patients actually died during follow-up, meaning that maybe they needed more treatment from that. So in 1967, the Uganda Cancer Institute was established as a collaboration with the National Cancer Institute of the United States, Makerere University, and Mulago Hospital. And it started as a treatment center for Bucket lymphoma, as it had been described by Dr. Bucket and his colleagues. So it became one of the initial sites of chemotherapy, combination chemotherapy trials. As you can see in the image here, we have our beautiful old building, and there's a signage there that Uganda Cancer Institute, as it was back in the years. And these were the beautiful vehicles and ambulances that we had at the time. So they used to follow up on the patients, going deep into the villages to follow up on them because of the poor infrastructure in terms of transport. So here we see a 1968 visit to a community in eastern Uganda to follow up on patients with Bucket's lymphoma, because many of them, once they received treatment and they got a bit of response, they would not come back for follow-up. So I think many of you have heard about the LASCA awards, and the one for combination chemotherapy for lymphoma and acute leukemia in 1972 went to, Dennis Bucket, Paul Carboni, John Ziegler, and others for identifying Bucket's tumor and developing a successful chemotherapeutic treatment. They did research into Bucket's lymphoma, which yielded important information that got applicable to the chemical and immunological treatment and control of other types of cancers as well. So this was seen as one of the achievements for setting up, a cancer institute based on research. So this is the original building, but it was remodeled. The signage I showed you is still this one. We still keep it, but this was the Lymphoma Treatment Center. And when I joined the Cancer Institute many years ago, I used to treat both children and adults with hematological malignancies from this same center. And it had a small laboratory and a small X-ray unit where we could do basic X-rays. And actually, we're sharing this X-ray with the research team for tuberculosis. So cancer care in the past has faced a number of challenges, especially diagnostic challenges, where we could not clearly classify the disease. And actually, many of the children that were referred to as Burkitt's lymphoma did not have Burkitt's, because when you look at work that has been done, like reviewing some of the histopathologies and immunohistochemistry, some of these actually had rhabdomyosarcoma and other sarcomas. So we had a lot of misclassification of disease, but many of them still had lymphoma. The leading causes of cancer death among Ugandan males and females have been Kaposi sarcoma and cervical cancer, respectively. Treatment is burdensome to both patients and health workers. It is frustrating when you cannot access any of the effective medicines, and many of the patients presenting quite late because of a number of infrastructure challenges and financial challenges. That's why in the introduction you heard Dr. Rondelli saying that I've been doing a lot of palliative care. At some point, the only where we could take care of our patients was to offer palliative care to them, because many of them are presenting with the late stage disease. They don't have good supportive care, and what we're doing is hospice care most of the time. There's limited access to blood products, especially when it comes to patients with hematological diseases. We don't have the array of antimicrobials, and where we treat the patients from may not be the best environment, especially if you compare with how it looks like in other facilities. So the mortality and morbidity is really high and unacceptable. This is again to show you where the LTC is in 2012, when we put new iron sheets and trying to change the environment a bit. So there have been advances in diagnostics. We now have access to immunohistochemistry to really help confirm with some of these diagnoses. Treatment is based on guidelines. We have tumor boards, and UCI and the NCCN, we are working together with the African experts to harmonize treatment guidelines that can work within Africa, within sub-Saharan Africa specifically. We have access to more medicines. We've been a bit strategic as Uganda Cancer Institute to procure medicines directly from the manufacturers, and this has reduced on the cost. And I'll show you how we have done that and the strategy we took. So, for example, we can access some monoclonal antibodies like rituximab for our patients with lymphoma. We are able now to getting diagnosis of HIV-associated multicentric Castleman's disease. We have a little more accommodation. We got from this building you've seen. We now went to get another facility that we can use. But before that, the collaboration has helped us to get into collaborations. And one of our collaborations is the Uganda Cancer Institute Fred Hatch collaboration, which was launched in 2008. The original focus was really to do research that included discovering and understanding infection-related cancers, including lymphoma associated with EBV, sarcomas associated with HIV, and cervical cancer due to persistent HPV infection. The focus is now changing a bit to include other cancers, including breast cancer. So this building you see actually replaced the original Cancer Institute or the Lymphoma Treatment Center. Where it is sitting is where the original Lymphoma Treatment Center was, the one we saw in black and white. So this is now the 6-level inpatient building, which has, operating rooms. It has space for pediatrics. It has space for the lymphoma and leukemia people, as well as a small private service. It also has a provision for patients with solid tumors, who, by the way, contribute to the biggest number. I may not show you how they are because, if you talk about beds, for us we talk about space. If someone can find where to put their head, that becomes their bed. It's not about, I have a bed and I'll be seen. So that's how it has been. Now, as we're still struggling with space, getting medicines, we hit the news. What you see here is what was our famous teletherapy machine, the cobalt machine. It got broken, and you see we had tried to do good service on it using tape, a number of things. So we used this for a long time as the only modality for treatment of patients with cancer who needed teletherapy with radiation. So it was donated in 1995, and we used it, and now it's broken. We hit the news. So we became famous for a broken machine. We started with the BBC, and the headline was Uganda cancer patients in limbo after radiotherapy machine breaks. The Guardian also reported on us. Uganda's radiotherapy machine has broken, but crowdfunding isn't the fix. So they wrote about that. And in the image below, it was still showing the machine. So again, in the BBC, surviving cancer in a country with no radiotherapy. So at this time, we didn't have any radiotherapy, and our patients continued to come to the facility despite lack of this, so they could get other services, including palliative care. In the Lancet, it also had appeared radiotherapy challenges in Uganda. And they say that Uganda's only external beam radiotherapy machine has recently broken down. It had been donated to Mulago National Referral Hospital in 1995. But the good news was that a new machine had been ordered from the International Atomic Energy Agency, and it was expected to arrive in about 6 months. We appeared in the Journal of Global Oncology. Broken machines or broken systems. The road to meaningful global radiotherapy access. So we became a bit famous because of that. Okay, so moving on, this is how our patients sometimes look like when they're waiting to be attended to. They don't have a designated, waiting area. We don't have a booking system where you say that I'll be seen at 11 or 12:30. It is first come, first serve. And as you see, all these want to be seen, but the doctors to see them might be less than 2 who are going to see all these patients. When radiation oncology, when the machine broke down, of course, we started working hard to make sure that we reinstate the services. So here you see a bunker being constructed, and we planned to not to construct for one banker as we had, but to construct for at least 6 bankers that were able or would be able to take care of at least 3 linear accelerators and then high dose rate brachytherapy machines. So this was the beginning, I mean, somewhere in the construction. And here we're starting to see the light at the end of the tunnel, that the facility is getting almost ready. What I talked about, a machine coming from the IEA, we bought a new machine. But before that, we had support from the Aga Khan University Hospital in Nairobi, Kenya, who helped to treat some of our patients. So we would send those who could afford to travel. They could afford to travel to Nairobi, and then they're given free treatment. So we procured a new cobalt teletherapy machine, and we started on the process of procuring radiation equipment, including linear accelerators. So this is the machine that had just been installed. Today in Uganda, we still have cancer. And we still have breast cancer, lung cancer, and colorectal cancer, and prostate as dominating. Cancer of the uterine cervix has reduced a bit, and it used to be a second to, at some point, it was even more than breast cancer, but now it is at 3.6%. So, because of the challenges that we faced, we advocated for a new way of approaching things. And one of these was to, advocate for Uganda Cancer Institute to become an autonomous institution. So an act of parliament in the Uganda Cancer Institute Act of 2016 was brought in to establish the Uganda Cancer Institute as a body corporate to provide for the functions of the institute, to establish the board of directors of the institute, etc. So this helped us to become self-accounting, given the fact that we have a lot of work that we do that may not be similar to what it is in mainstream medicine. And the purpose of the act was stated clearly that the purpose of this act is to establish an autonomous cancer institute with the mandate to undertake and coordinate the management of cancer and cancer-related diseases in Uganda, to establish a modern cancer institute with international standards to address the challenges of treating cancer and cancer-related diseases. The other purpose of the act was, and still remains, to reduce the referrals of cancer patients abroad, to ensure timely access to highly specialized cancer medication and increase the capacity of Ugandan oncologists to handle specialized cancer conditions, and to empower an institute that will oversee the management of other health units which handle cancer-related conditions. So all the things that we're doing now are based on this act, because it is giving us the mandate to do a lot of things, but also giving us responsibility to see how we can make it happen to implement this. The services that are currently available include medical oncology, hematology, gyn-onc, surgical, pediatric oncology, specialized pharmacy, palliative care, research and training, pathology services and laboratory services, although they may not be to the level that we wish to be at, and then radiation oncology. Again, to remind you that about 10% of all the cancers we see at the UCI are children. So we've tried to, improve what we have. We have mammography, that is to help screen for breast cancer. We actually also have a mobile van that goes to the communities. We have a CT scan. We have X-ray and ultrasound machines, again, to help with imaging of our patients. So, fast forward, the radiotherapy machine dead. Now we acquired new equipment. We acquired a TrueBeam linear accelerator, and this is currently in operation. We added, a patient waiting area, so they don't all have to sit in the compound, and the doctors have offices where they see the patients from. So this has been an achievement that we feel proud of. One of these equipments we have, now we have 3 linear accelerators. We have 2 Cobalt 60 teletherapy machines, and we are trying to actually phase out the Cobalt teletherapy machines because of challenges associated with them. We have high dose rate equipment that are using Cobalt, and we are using now 3D from 2D planning systems. And I think now the experts in radiation oncology have added other things like VMAT and others. We are able to at least treat better than we used to treat our patients who need radiation. There's a lot of research and training going on at the Cancer Institute. We have fellowship programs in medical oncology and hematology for adults, pediatric oncology and hematology, fellowship in gynecology, oncology, and radiation oncology. Uganda Cancer Institute was built on research. So we continue to, carry out research in partnership with different institutions to conduct high quality research in basic and translational cancer science, epidemiology, and implementation science. As you know, a lot of research happens in Uganda. Most of the HIV, related research, like prevention of mother-to-child transmission, use of Septrin, Uganda was part of the centers that participated in these trials. In terms of training, we have, our trainees. This is a pediatric oncology fellow. He has now completed as part of the East Africa Center of Excellence in Oncology. And a Center of Excellence was actually brought in by the East African community, where Uganda was selected to take leadership in oncology training, care, and research. And we have our children who are playing as they receive their treatment. These are some of the staff at the Uganda Cancer Institute. This is laboratory staff, still laboratory, then the surgeons are doing their work, and our wonderful team of nurses. Now, when you look at this, I don't know if any of you has ever been to such a place. I don't know, but many, in around 1990, late 80s, after the Bush War in Uganda, we had a lot of people who were internally displaced in the northern region. And this is a protected camp where they would stay. And many of them actually, even those who are outside the camps, were living in such conditions. Some still do live in such situations in the northern part of the country because of the insurgency, with very limited access to health care, including cancer care. So many of the patients have to travel over maybe 9 hours on the road to come to the only center, the Uganda Cancer Institute, for treatment. And when they get treatment, following them up becomes a challenge. They don't have transport. When they come in, they have nowhere to stay. So many of them will end up living either at the verandas or anywhere where they can find space. But this situation is changing because better facilities have come up in northern Uganda, and Uganda Cancer Institute has moved to northern Uganda. We now have a Northern Uganda Regional Cancer Center, which is to support the Great Acholi and Lango region. Of course, we expect patients from South Sudan and other parts of, Eastern Congo and other places. The center is almost open, but and it is well equipped. We have good operating rooms, we have imaging, we have provision for chemotherapy, infusion, and provision for inpatients, those who need to be treated as inpatients. Radiation oncology is going to be added in the future. And this was done under a turnkey project where, we advocated for getting funding and that those who give us the funding can actually implement. The reason for this is to avoid, the technical challenges associated with money when it comes to a country, especially in countries where we come from. Coming up next, Uganda Cancer Institute is going to continue working. We have a master plan. We don't know when we'll implement, but we hope to have, modern facilities. We have provision for a PET center, and actually procurement for the PET center started, and some of what it takes, the implementation has begun. And then this is up the hill of Mulago Hospital, where we hope, it's a big dream, but we hope we shall be able to achieve whatever we can achieve. We need to decentralize cancer care because it's not practical to have every patient come here to the Uganda Cancer Institute. So now that we have the northern region, we have the western region at the university in Mbarara, University of Science and Technology. We have our presence there. We need to go to West Nile. On the map, we could have seen that. And we need also to go to the eastern part of the region. All this is in our work plan as we move on. So these are the areas that we need to make sure we collect, data through population-based cancer registry, because at the moment, we only have the Kampala Cancer Registry, which is very, very tiny. And for a long time, it was the only population-based registry in the region. And we now have Gulu Cancer Registry. So all the data that we get on GlobalCan is mostly from the Gulu Cancer Registry and the Kampala Cancer Registry. We are moving to the eastern part of the country where we have a Mayuge Cancer Registry also coming up. So we hope that we'll expand to 5 population-based cancer registries to feed into the National Cancer Registry and be able to get proper data on cancer patients. This is our radiation, and as I said, we are continuing to improve. We have the equipment, but we are also trying to improve, the techniques to add on more techniques. Initially 2D, then 3D, now they do VMAT and others. You can tell I'm not a radiation oncologist, but at least a number of things are happening to improve care for our patients. We have a multi-purpose building, which has been constructed by funding from the government of Uganda. It has a number of clinical services, including operating rooms, intensive care unit, and a bone marrow transplant facility. We have lecture rooms and an auditorium that once we activate it, it will be really a good thing for us. To demonstrate the political will that we have, here we have the Speaker of Parliament, Deputy Speaker of Parliament, the Chair of the Board of the Cancer Institute, the Director of the Uganda Cancer Institute, and there was truly Henry Ddungu here. We were inspecting the facility to see whether actually we are up to speed. Of course, there's still a few challenges, but at least it demonstrates the willingness of government to support us. We are getting ready for hematopoietic stem cell transplant. As I said, we have the political and administrative will. We have a multipurpose building. We have procured apheresis equipment. And here we have two of our nurses who have been trained in apheresis, and they've been able to collect platelet products for our patients. We are training more personnel, physicians, nurses, and the reason why I'm here is because I'm here for training. We have tried to identify those that we can partner with in India, in Canada, and we are looking forward to support from the global bone marrow transplant program from here. And we think the only way we can build a modern cancer service in sub-Saharan Africa is going to be based on clinical research or clinical research care model, as says Dr. Jackson Orem. So this can be done through academic centers of excellency with the commitment of individuals and governments of African countries. I can assure you we are committed, and we are looking forward to getting support from you to see how we can also get our patients benefit from good services. And I welcome you all to come to Uganda, which is the Pearl of Africa. And I thank you so much for listening. Thank you very much. I don't know if we have any questions.
If you have a question, you can raise your hand and I can let you ask for yourself.
I have a question while people are signing up with other questions. First of all, thank you very much. It was a great talk. Henry, I think one of the issues here is to patients' access to how available will be these treatments to the patients, what kind of insurance or payments they have to face. And the other thing is, how many physicians do you project will be needed to cover all these services? A few days ago, we were talking about how many hematologists in the country. You told me 6. So how do you project the need and the capacity in Uganda to address the cancer care?
Thank you, Dr. Rondelli, for that wonderful question. In Uganda, we do not have a national insurance, and all the care at the moment is provided for by government. As we set up these advanced treatments, we are still providing almost 100%. Sometimes patients have to contribute towards certain services as a way of cost sharing, but so far it's government service. We hope that, and with the authority given to us by Parliament, we may come up with a structure of a minimal fee to see how we can sustain this. But I hope it will not be as bad as when you send a patient out of the country. Even if they have to pay some money towards a transplant, it will be way cheaper than sending someone to India, where they have to pay for an air ticket, they have to pay for accommodation, and then they will pay not less than $30,000 for their treatment. The number of physicians we plan to get, I can't have the actual figure, but as you realized, we need more. We cannot have 6 hematologists, and some of them are actually retiring. We need to train more people. That's why we are working on training of more people so that we have at least coverage for all the regions. So we are talking about hundreds of specialists that are needed. Thank you.
Thank you. There's a question on the chat. As Kaposi sarcoma and cervical cancer are the largest two contributors to cancer mortality in Uganda, and these are largely preventable, what national efforts do you see regarding cancer prevention? For example, HIV treatment, HPV vaccines, and other cervical cancer screening?
Thank you so much. That's another great question. As I showed you in how it is today, because that was then, today, cancer of the uterine cervix has actually come down, and Kaposi sarcoma has also drastically reduced in Uganda, especially for those who can access care. This has happened because of a national rollout program for HIV treatment, but even before treatment, campaign to prevent HIV infection. So our infection rate is less than, I think, 6%. And in terms of cancer screening, we have a program for cancer screening. We encourage all health facilities to screen for cancer of the uterine cervix. And there is vaccination of young girls against HPV. And this is contributing to a reduction in the number of cases. And we hope these numbers are going to reduce even further as we move ahead.
Another question from Hussein, and who's asking, is the Uganda Cancer Institute funded by the government or private donations? And will future projects and plans for UCI be funded in the same way?
Yeah, it's currently funded by government. You know, initially, we were not, as a government entity, would not get money directly. But now, we are hoping to, to get funding privately if we can, funding through, other collaborations. So it is something that we are really looking out for to ensure sustainability.
Okay. I think I don't see any other questions on the chat. If nobody else has other questions, let me ask you one last question. I mean, Uganda is a key country in East Africa, and the need of what you demonstrated in Uganda is probably actually for sure true also in surrounding areas, surrounding countries. So how do you connect with the other countries surrounding Uganda, or connect to Uganda for cancer care, for training, or is there any network that has been established?
Yeah, thank you, Dr. Ranila, again for this. Uganda is in East Africa, and we have an active East African community. The community was initially made of 3 countries, that is Uganda, Kenya, and Tanzania. But now South Sudan has joined, the DRC has joined, Rwanda, Burundi have joined, and now it's a bigger community. As we are centrally located within this community, we anticipate that other countries will join us. And it has been like this, that much as we have not the best cancer treatment services, but we've been receiving a number of patients from South Sudan, the eastern part of Rwanda. Of course, we get a number of people from the eastern part of the DRC to come in. And we think if we come up with all these super specialized programs, they're going to serve the region. Many of these people have been trying to go to other countries for treatment. If we put the treatment closer to them, we are going to be helping the community. And I think we'll be supported by the East African community as well to advocate for more resources to make sure that we establish good cancer treatment in the region.
One more question came up from Giovanna Machado Kazuka. You talked about providing palliative care to the patients. How is this type of care provided? Do you have a specific team dedicated to palliative care?
Well, that's another good question. For a long time, we did not have a dedicated palliative care team. We are working with hospices that are around us. And one of the oldest hospices and the founder of palliative care in the country is Hospice Africa, Uganda. So we would refer patients for home-based care to go to hospice, and also get doctors and nurses from Hospice Africa, Uganda, which is so close to the Cancer Institute, to come and visit patients in the hospital and then talk to them, and discharge planning starts. But now we have an in-house palliative care team, although very small, but at least we are trying to build on that. But what we've been working on mostly is our doctors and nurses referring the patients to the regions. We work with the Palliative Care Association of Uganda to help identify patients where they can go when they go back to the districts. As you know, Uganda has so many districts, and we have a number of providers in each of those districts. So by working with the association, we are able to identify where to send our patients.
Well, maybe we have one more question. Since a few minutes are still available. Cancer care, by definition, requires a multidisciplinary approach, both from a diagnostic perspective in terms of radiology, pathology, but also for treatment, not only the radiation therapy that you described, which has made a lot of progress in Uganda, but also from intensive care unit, infectious disease treatment. Patients with cancer get complications, can have multiple needs of other subspecialty to support. How is this growing? Is this growing together with oncology, or is it capacity differences in these areas?
Yeah, we have a multidisciplinary team. We have a diagnostic capacity that we are building. We have a team of nurses who have been trained in oncology and chemotherapy infusion. Indeed, I did not show that, but we give a lot of chemotherapy infusion, most of which is palliative, and the imaging services we have. We don't have advanced imaging like PET, but it is in our plans, and the procurement process started. So the challenge we have is we don't have like a designated infectious diseases team. We don't have a good transfusion service support, and our patients are at a very high risk for infections, including malaria. Many patients, when they're neutropenic, they actually develop severe forms of malaria. We have patients who bleed when they have infections and they're neutropenic. So these are big challenges that we are trying to identify. And one of the strategies is to, come up with space. Instead of putting all patients together in one room, we may have to at least reduce on the congestion and see how we can reduce on this. And we are also borrowing ideas. For example, effective hand washing, we think, can prevent a lot of some of these infections.
Thank you very much again, Dr. Ddungu. It's been really a pleasure, and I think we all learn a lot. And I think many of us look forward to seeing you, to visiting with you in Uganda. If there are no other questions, I want to thank all the participants in the webinar. Thank you for being with us today, and will be announcement soon about the next colloquium for next month. Thank you very much, and
Thank you.
Goodbye to everybody.
Thank you.